Welcome to Caregiver Relief Podcast. I'm your host, Diane Carbo, a registered nurse. Before we begin today's episode, I want to ask you a question. Did you know that some of the most commonly prescribed pain medications for seniors can actually increase the risk of falls, confusion, hospitalizations, and even loss of independence? For family caregivers trying to help a loved one manage pain, this creates a difficult dilemma. How do you relieve pain without causing more harm? Today, we're going to answer that question. Today's episode is one every caregiver, older adult, and healthcare professional needs to hear. We're talking about pain management in seniors without relying on risky medications. To help us navigate this important topic, I'm joined today by Mark, the pain guy Garofoli, a nationally recognized pain expert, board-certified geriatric pharmacist, certified pain educator, and a TEDx speaker. Mark serves as faculty with the West Virginia University Schools of Pharmacy and Medicine, where he works at the intersection of pain management, geriatrics, and addiction medicine. He has advised major health systems, served on state and federal pain initiatives, and is dedicated to helping healthcare professionals and caregivers better understand safe and effective pain treatment. Today, we'll unpack what caregivers need to know about safer pain management, how to avoid medications that do more harm than good, and how tools like the AGS Beers Criteria can help protect older adults while still addressing real pain. This episode is sponsored by myvitalvault.net, your all-in-one life organizer for aging adults and caregivers. It's designed to help you securely store your essential legal, medical, and emergency information in one easy-to-access place. Because when a crisis hits, being prepared can make all the difference. Join our Caregiver Relief community, a warm, welcoming space where you can connect with other caregivers, ask questions, share stories, and find support from people who truly understand. Visit community.caregiverrelief.com to join now, because caregiving is one of the hardest and most meaningful things you'll ever do, and no one should have to do it alone. And if this episode speaks to you, please take a moment to like, share, or comment. Every click helps us reach more caregivers who need encouragement, resources, and hope. Mark, thanks so much for coming out, taking time out of your day to share your knowledge. We desperately need it.
Absolutely. And thank you as well, Diane, and everyone listening, of course, too. Quite frankly, I'm a firm believer in time being our most important resource. So not only are we here today, but to everyone listening, want to thank you as well, too. It is an absolute pleasure to be here to hopefully help us not only with patient care, but hey, hang out with our colleagues professionally as well, too, to dive deeper into pain management for our older adults.
And it couldn't come at a better time, Mark, because we have a crisis in America right now, especially with Medicare. Medicare is not only rationing our pain management visits and procedures that are meant to take a decrease or eliminate use of medications, but they're also making it hard for seniors to get drugs. And I can't take them, and I have chronic pain. So I'm really excited about you sharing your information with us today. But before we dive in, can you tell us what first drew you to specialize in pain management and geriatrics?
Probably everyone listening in. My early days as a pharmacist, I was in community pharmacies. I was eventually working within managed care as well, and different settings along the way. But I always go back to my days within a community pharmacy. They're either everywhere or nowhere, literally, because there's usually two on a corner, if not three, readily accessible for most of our country. A high percentage, like 90% or something like that, the last thing I read. But then, what if you're in that other 10%? Then, and you got to drive a half an hour or something to find anyone in healthcare, let alone a pharmacy or hospital. But the bottom line is you get a lot of touch points with people in communities. And profoundly, there were so many people coming in pain. A lot of other things too. I often get other healthcare professionals be like, people had hyperlipidemia and cardiovascular concerns and this and that and diabetes and yeah. But you know what they want to talk about? The thing
Okay.
that's hitting them every minute of every day.
Yep.
My blood sugar level is important, but I'm not thinking about it right now. But if I'm in pain, bet you bottom dollar I'm thinking about it. So it,
100%.
maybe it's very American or something of click the button and I want to receive something immediately. But when you help people in pain, it might take a while, but once it hits and there's effects on a safe and efficacious route, it's very fulfilling. And there's just so much. Everyone's either on a right side, a left side, or up or down or all around in the realm of prescription opioids. And it's either opioid philia or opioid phobia. It's like there's nothing in the middle sometimes. And,
Yes.
you mentioned the AGS Beers Criteria. A lot of folks we used to call it to the beers list. It sounds like a menu in a
I
good
know.
establishment. But and I will say, by the way, that it's about probably one of the most clinician friendly guidelines out there because it's organized by charts or tables
Uh-huh.
instead of paragraph upon paragraph. Or clinicians, we like to digest things really quick and help our patients. Tricky part is there's a lot of words within the tables, but at least it's organized in that way. It's just one of those things where it started out just talking with a lot of people and realizing, reading the room and realizing that there's so much convoluted information out there and opinions are a dime a dozen. And who do we trust? It's one of the biggest questions today with so much misinformation out there of who do you trust and why? And our seniors, our older patients in pain, good golly, we got to help them. Hey, maybe it's a selfish thing. Hopefully, we're all an older patient over 65 someday, if not already. So, what's good for the goose and gander and all that jazz is very important along the way.
Pain often looks different in older adults. What makes pain assessment and treatment more complex as we age?
There's a lot of things that change in our body as we age. Quite frankly, everything.
Yeah.
When I say a lot of things, our entire bodies change. It's just how it is. Change is part of our life. But some things stand out. Our immune system, perhaps a little bit less effective. It's not going to come into play as much for pain medicines, but more good old kidneys and heart, things change there as well, too. I've seen multiple fun reads and movies on the Fountain of Youth and all of that of, what if that thing ever existed, it would literally affect our kidney function. Whatever the heck you drank out of that fountain would affect our kidney function and either slow down the digression of it
Uh-huh.
or improve it. Because that's what gets us. Like, no matter what, when you see 100-year-olds or 100 and some year olds living so long, I hope to get there someday healthy along the way as well, too. But things change in our bodies, regardless of how vibrant our days are and active we are and eating and all that. Things just change. And that's where it really comes. It's not to discredit, say, on the pediatric side, pain management is pretty darn important in that regard, too, the
Yeah.
extremes of life. But there's just, and the population is huge in a good way. People didn't used to live this long. Oh my gosh. I saw one of our recent drug czars recently. He actually came to our wild and wonderful state of West Virginia, our town actually, and was going over like what changed over the last couple hundred years and various things within healthcare, various other things out throughout society, but everybody's living longer. Yeah, 100 years ago, people weren't, I wouldn't be here. Y'all wouldn't be here. So there's more of us, and that's a good thing. It's a first world problem, but we got to be able to be there and help folks too.
We also have a situation right now with more seniors than youth. The low birth rates has negatively impacted future care for all of us because we have no one to take care of us. So, from your experience, Mark, what are the most common pain related mistakes people make unknowingly when they're trying to help their loved ones or help themselves?
Oh, where do we go wrong? So perhaps the best person to ask is a healthcare professional, because by golly, we're like the worst patients. Okay.
I'm one.
Yeah. Well, okay. You'll admit, I'll admit,
Yep.
you're listening, whether you admit it or not, it's just how we are, right?
Yeah.
Conversely, there's the folks that stroll into any clinic or pharmacy or hospital or whatever, and they're like, oh, yeah, Dr. Google said this and AI said that. And it's
Yeah.
my goodness, that's the other spectrum, right? But big picture, it's when you think about us healthcare professionals when we are in pain. I've had my fair share of hopefully, thankfully, not too many, but I had a kidney stone one time. I hope and
Oh,
pray that
goodness.
never happens again. Done
Yeah.
everything I can to prevent that, but life happens. Sounds like we're talking nothing about kidneys here today now that I realize it, but it's just one of those things. But it's very tough And with knowledge comes power and responsibility.
Yes.
And the times that I've personally navigated our healthcare system as a patient in pain, oh my gosh, it's eye-opening because you're skipping over a couple things of, again, if there's blood pressure concerns, diabetes concerns, things like that are very important, but it's not going to make headlines if there's changes in the treatment of diabetes for a single patient. But, all of a sudden things can hit the fan if it's a patient in pain that's just trying to get their pain taken care of. And more often than not, as you articulated earlier, it's an older patient in pain because just statistically through our population. And you walk into a clinic, maybe even urgent care, and I experienced this one time. I walked onto the scale because that's how you get triage and all that. And right there, right in front, it was like, we don't give any pain medicines out. It's like, your urgent care. What's more urgent than pain? A couple things, by the way. It's at the top.
Yeah.
And that's tricky for patients and whoever is the patient, quite frankly.
I have a son who had RSD, reflex sympathetic dystrophy, or chronic regional pain syndrome.
Mhm.
And as a healthcare professional, and I've worked with other people with severe pain conditions, and our healthcare system, our providers just let us down. Like you said, they come in, we're not giving you any more pain. I have a sister who had a chronic pain. It turned out to be a RSD of her abdomen from a surgical procedure gone wrong. And she was not, she was wearing pain patches and stuff, and she was just going to turn 65 recently. She goes to the ER all the time, and they finally told her, "We can't do anything more for you." So she thinks she's dying. That was the message she
Gee.
was given. And I just told her, "Nancy, they just can't handle your pain. You have to look at other things to do because they're giving you everything and they just see you as drug seeking." And that's really a hard thing to face.
It's so unfortunate.
It is, because the first thing they say, here's the cycle that most people go through. You go to the doctors, you have an acute injury. Oh, they'll give you pain pills, send you home. Then you need more. And like with my son Jeff, they get build up a tolerance to the pain. So what happens is you need more. Then they introduce pain management to you to get off of all the meds and try other things. And it's just a cycle. So that's why this title is Managing Pain in Seniors Without Risky Medications. Tell me, what does risky mean and what does that actually mean for older adults?
Risk is such an umbrella term.
Yeah.
It's when you look at medications in general. So here, I can't speak for all pharmacists, but I'll give it a whirl for 10 seconds. What we concentrate on, okay? Whether knowing it or realizing it or not, here is an elevator spiel. How does it work and how much? So, what's the mechanisms of whatever medication or treatment for that matter, even if it's non pharmacological, not medicine? How does it work? And then how much of it? Our father of toxicology, he had a quote well known. The Latin is solidosis facit venenum. The dose makes the poison. What he was saying was he didn't really care about how it worked or what it was, just how much, which is very important and really drives it home. I always say it's all about the dosage, baby. But how does it work and how much leads to safety and efficacy. Efficacy, hey, does the thing work for whatever you're using it for pain? Does it improve function? It could improve that little pain scale, the numbers, dare I say, but really about function. The safety side is where that risk comes in, or there's our interactions with other medications, food, beverage, you name it, and side effects. Philosophically, that's what we call them. The
Mhm.
substance itself is like, this is what I do. You can call it a side effect, you can call it efficacy, you name it. But risk comes into play with those side effects and how frequent they are, how likely they are, and what they are. When we're talking about higher risk medications, generally speaking, in pain management, we're obviously speaking about prescription opioids. The difference between constipation and respiratory depression is more than appreciative,
Yes.
but it's also dose related and selection of which opioid related. And hey, insert us human in there too. We got a lot of different things going on between all of
Yeah.
us. So the risk can go down to it's not, it tells somebody that gets constipation from an opioid that, oh, that doesn't matter. Of course it matters. I've actually been there for crying out loud. Like, it
Yeah.
matters.
Yeah.
It's different than not being able to breathe and dying, though.
Yeah.
But there's risk inherent with each of those. It's just to what degree and what the outcomes could be, really.
So, what are some common pain medications or medication classes listed in the Beers criteria that people should be especially cautious about and why?
When we're talking about the AGS Beers Criteria, my short answer to that, if it was a multiple choice question, is either all the above or yes. Take
Okay.
your pick, audience, whatever you prefer there, okay?
Okay.
Another version of
All
that,
the
and by the way, I will actually articulate an answer here, but another version that's actually come out of this mouth before is, okay, if you look through the Beers Criteria, one of about a half a dozen go-to resources for treating anything with medication in our older adults, here particularly with pain management, but there's other tools out there. Anticholinergic burden scales, all of a sudden this got
Yeah.
nerdy really fast, but there's other scales, but that's one of the main ones. When you're looking in there, there's different, I think I mentioned earlier, there's different tables. One of the main ones is the potentially inappropriate medications for use in an older adult. Usually just say PIMS, that potentially inappropriate medicine part. So the PIMS are in there, but then the other tables go into what if the patient has XYZ condition? What if their kidney function is ABC? All these different things that are very common in older adults because we're humans and we're aging and this stuff happens. So when you look at it through that lens of reality, all of us,
Mhm.
and they keep nicking away at, oh, we recommend not to utilize this, not to utilize that, not to utilize this, because there's a lot of risk, as you mentioned, that's inherent and possible with any medication. So if you have the average older adult strolling into a clinic or a pharmacy, odds are they're qualifying for multiple things within the AGS Beers criteria. And all of a sudden it's like, what's left? When you whittle away, like opioids, it's not every single one is listed in there, but the concept is there. Then you have NSAIDs, or non-steroidal medications, even the
Yeah.
over-the-counter versions, or the plethora of prescription ones. When you look granularly at that guideline, it literally it almost sounds like a drug rep from the 80s or 90s. It literally says, "Okay, there's 20 of them, almost.
Yeah.
Just use this one, okay? All the rest, don't worry." And folks, if you're wondering, because there's no video, my hands are going a mile a minute here, okay? The Italian has come out, but just this one, okay? It literally sounds like what we're supposed to not listen to as far as, like pharma or something. But the guideline says for the most part, unless there's other additional conditions, celecoxib, that's your go-to in an older patient. So they just knock out the other ones. There are patient specifics that could come into play with that. And there's a reality to what they're going with as well in that, based on thousands of articles in the literature. There's a lot of good reputation going on there. But boy, that's coming in hot. And then, oh, if you have these other conditions, by the way, don't even use that one. If
Also
they're
confusing.
so you're whittling it down, and all of a sudden it's okay. What about the or adjuvant pain medications or antidepressants that could be helping in pain profoundly? When you look at those, oh, a lot of them they're used in pain are anticholinergics. Ooh, that's a fall risk, which by the way, I fully endorse because it's fact.
Yeah.
But again, when you're crossing off the list, it's what are you left with?
Yeah.
I've been on record to say he got half a Flintstone vitamin left when you go through the whole list. And it's
Yeah.
like,
Yeah.
and I'm just saying that facetiously, folks. There are a lot of different pain management treatment options out there. The toolbox is actually rather large. It's just honing in what medicine, what treatment, doesn't need to be a medicine, but what treatment for what patient. And that's why a lot of folks will reach out even to yours truly and be like, it's like a consult on the fly. What do you recommend for this? First, they need all the info, then time, and all of a sudden now we can't answer. It's tricky, and we're limited on time as patients and as healthcare professionals. When you have the quintessential 15 minutes to do
Yeah.
about 30 hours worth of work,
Yeah.
then we wonder why didn't the care go well? When it's all an algorithm, it doesn't also always work out in the end. So that's some of the medications, just trying to jump through them there. One of the other actually cool things. So in case the sentiment was negative on that guideline, because it's not, but just based on assessing my own tone and everything, for decades, that Beers criteria has been around. And there's never been that final piece of, hey, why don't y'all also publish, if you're recommending not to utilize this, the alternatives that you are recommending? And by golly, a couple years back, finally did that. It's like, hey, here's a list of what we recommend not to utilize based on tons of research and data and all that. And here's some alternatives along the way as well. I was taken back. I was joyful, But then also I was like, man, my presentations that I do on this, that's what I've always been doing, to be like, you can't say don't use this without saying what is the alternative.
Wow.
I'm like, oh, now everybody can do that. That's good. We're moving the bar along the way. So that's a positive thing. Yeah.
You mentioned non-drug or low-risk approaches to pain management. Can we talk a little bit about it? Because I'm
Sure.
doing a whole series on that.
Mm,
Yesterday I did a podcast with Dr. Harrington on class 4 laser therapy.
okay.
And so I'm looking at alternatives because and the reason why I am is because I'm a person who has chronic pain. I tease and tell people I used to pick up men for a living because I literally did because in the days was a nurse in the dark ages, and we had Hoyers, but we didn't use them very often, and I worked at rehab, so you really literally did fireman lists and move patients over the wheelchair and stuff, so my body's a little broken, and I go to pain management, but now all the procedures that are meant to delay or decrease or eliminate pain meds, which I can't take anyway, they're rationing them. So I'm trying to do a lot more research for people in the same position I am in. I want my pain relieved. So I'm really interested in what some non-drug or low risk approaches are.
And thankfully we've gotten a lot more information within various guidelines these days on
Yeah.
those non-pharmacological options. How I usually group things. You've got I think you mentioned some procedures there. So the interventional procedures,
Yeah.
they come across, it's oftentimes they involve our spine. So
Yeah.
I'm not downplaying somebody going into a spine. In fact, I hold them up on a pedestal for our interventional docs out there. I work with some, they're amazing. Okay. To them, though, it's like playing darts in the bar.
I
It's
know.
literally, gosh, who hasn't watched Grey's Anatomy or maybe these days The
Yeah.
Pit? If you ever notice, like, oh, in The Pit, it's the ER. They're not exactly just crocheting or something. It's not that calm. But when you notice surgeries in fake shows with
Yes.
you, but based on reality, they're throwing it. They're talking through their lives or whatever because they're comfortable in what they're doing. It's almost like they're not paying attention, but that's how you work through it when you're a master at what you do. So
Yeah.
you want that comfort level along the way. And that's something that's seen within intervention. And I want patients to know that. Because if you're strolling in to have a procedure on your spine and somebody's talking about the sports game from last night, you might have some concerns, but you should know, no, that's what I want to hear. By the way, what was the score? Anyways,
Yep.
along the way. So there's interventional, but then there's the plethora of the non-farm options. I personally usually group into, I sometimes live on my own island or have different perspectives, but I say they're grouped into active and passive. Now, different guidelines will point out very specific things like chronic lower back pain, where we have guidelines out there that have been vetted and look through all the literature to show that massage is a thing, chiropractor is a thing. We already knew that, but then there's evidence for it along the way.
Yeah.
Acupuncture, you name it along the way. That thing's been around for longer than practically the earth itself. Like,
Yes.
oh, what about the studies? Good golly. It's like Adam and Eve and then that and other things went Eastern along the way. But the way that I like to look at it is patient centric, right? What do you, as the patient, what's your expectation? What do you want to do? If you want to sit back and be taken care of, that's passive. Okay, maybe massage is a thing. Maybe Tai Chi's not, because you got to get up and move and stuff. Whereas if you're like, I want to be part of this, I want to take care of this, I want to be active in my care. Okay, then maybe not lay back and get a massage because probably still relaxing, by the way, which medical ones are very different than spas. But anyways,
Yeah.
not my forte, staying in my lane here as a pharmacist, but we all work together. Hopefully, at least I get to. So it's really the distinguishment with the active, passive. I mentioned a few there overall. There's so many more as well. So that other episode or conversation that you're having, it'll probably end up being like 4 or 5 because there's just so many different options out there, which is a good thing. But it
Yeah.
comes down to figuring out which one for which patient. And by the way, I always like to emphasize the combinations. You know, how many folks, this is going to be the dumbest thing you hear all day as far as a question. How many folks have encountered a patient or been the patient that said, I've tried everything, doc? It is
Yeah.
mathematically impossible. Okay. By the
Yeah.
way, I am glass half full of anything you want to enjoy together. Okay.
Yeah.
Total positivity, right? But mathematically, that is physically impossible because if you take all the options and you do the exponential math on it for the different combinations along the way, and then add in the different medical conditions that are painful, it's just not possible. But boy, does it take a long time to figure out which combination is going to work for each patient, right? particularly when
Absolutely.
you're the patient. That's we see that with medications a lot because of side effects that arise. We're like, I'm not trying that one again. And it's, oh my gosh, they should have started low and went slow. That's one of the
Well,
slogans. Start low,
you're
go slow.
absolutely right, and
Because if you come in hot,
Yep.
then that medicine is off the menu for the
Yeah.
rest of someone's life,
Yeah.
potentially. And no guarantees, but maybe it could have been something that was both safe and effective at the right dose that Paracelsus guy said centuries ago. So,
I actually was put on gabapentin, and I started out 100 milligrams. Now, I know 300's a traditional dose, but I do what I preach. I walk my talk. Start at the lowest dose and work into it. 100 milligrams made me so dizzy that I couldn't stand straight. Just that pill, that one little hundred. And if I'd taken 300, I'd probably be in the hospital or something with a head injury.
it's
Uh,
interesting that you brought up, first off, by the way, let me not skip over. I'm sorry to hear that happen for you because
mm,
that's, maybe it's the pharmacist in me, probably the human in me. That's just, you had to go through that. Like that's, oh my goodness. Some things can be prevented, others can't.
yeah,
That's a generally accepted low dose, really.
yeah, it
As you
is.
said, walking the
Yes.
walk along the way.
Yeah.
We just don't depend. I don't know how it doesn't come up in conversations anymore. I've had my own podcast, the Pain Pod and the Pharmacy Podcast Network. I've gone over this a couple times with various guests and even yours truly of how we squeeze on opioids access and
Yeah.
others. I mentioned NSAIDs earlier, even what's left. All of a sudden, gabapentin is like the one that everybody goes to. And it's like, you can
Yeah.
see the ending. We've been there before. It's not psychic. It's just, it becomes common sense.
Yeah.
You have something that gabapentin, it's not a controlled substance federally speaking, but there's half a dozen states where it is a control. That sounds like a legal nightmare, but it's just, how does it work? Like other controlled substances. Then why is it not a control? Good question. I'm not in charge. I take care of patients and try and teach people. But the utilization along the way, when you mention that, the first thing that's popping in my head, I'm on the edge of my seat. I'm like, how'd that go for you? Because it's in knowing how it works, and you mentioned how much, it leads down the road of, oh, but and you mentioned risk earlier and the idea of prevention of falls.
Yeah.
Here we are talking things like AGS Beers Criteria and pain management in older adults. And no matter what the condition, it's all about preventing falls. For
Oh,
crying
yeah.
out loud, a couple years ago, my wife and I, we did not really remodeling in our house. Added some things, did some patio work and all that. And I was heck bent on, I want steps around our house. I got to the point of, what are these needed for? We're not, no one walks over on that side. And I'm like, cuss. I work with older patients and I know that it's all about preventing falls. And I know that I have a little tiny dose of stubbornness in me sometimes, not always. And it's going to rain someday when I'm 80, hopefully. And I'm going to go out there and I'm going to walk, and I shouldn't have. And I'm going to fall and I'm going to break my hip. And then as I visit the wonderful hospital, I may get an infection. And then next Tuesday, everybody's eating eggs or something else for lunch after I'm not around anymore. And I don't want that to happen. So let's get
Yeah.
steps everywhere
Yeah.
because it's all about preventing the falls. These medications, like you mentioned, gabapentin. Oh my gosh, there you go. There's so many different medications that could lead to that cognitive function change that ultimately leads to, if you are, it's like a rug sticking up.
Yeah.
You're gonna fall.
Yeah.
It doesn't matter who or what age or whatever, it's gonna happen.
My
And it's all about
reading
trying to mitigate that.
Yes, my reading has shown that gabapentin can lead to dementia,
That's
and
been one of the recent headlines, actually. Yeah.
yes, so I'm like, where do we find the happy medium? And I really think that one of the things we have to do is look at alternative treatments to medications because you want to balance comfort with safety when treating older adults.
Yep.
And that's a fine line, and you just made me aware of how challenging it is with what you
It's
have
an
to
art.
consider. It is an art.
And,
It is an art.
we often have the campfire conversations with learners, whether they're medical residents, medical fellows, student pharmacists, student nurses, you name it, about how failure is part of winning, quite frankly. And this
Yeah.
gets very philosophical very quick. But the whole reality, though, is when you work in healthcare, whatever your profession is, you're not always going to win. And that's just a reality. Now, hopefully, you minimize the risk, you minimize the negatives, obviously.
Yeah.
A patient having a minor side effect is also not a win, but it's also not death or something bigger along the way. And really realizing that on the patient side is incredibly important as well. And when I'm talking with patients, it's an adventure, it's a journey. This isn't some sprint or something, and things are going to change along the way. And that doesn't sound easy because it's not. But we will work together and get there. Even how defining pain, asking people. I do this and it throws people off so much. But you know what? In the end game, it helps. Like, how do you define pain? On my own podcast, I do that often with folks too, but even to patients. Because then, as the clinician, you're being told, here's my goals. Like, how do I define? Oh, I'd love to, we hear it often of that. I'd like to be able to walk out to the mailbox. I'm convinced people should start getting their mail delivered to their house. But, anyways, like the actual physical house. But, and beyond that, like when someone defines it, then you know what some goals are and you can go over what are the goals and the reality that, and hopefully smart goals, actual measurable and attainable things along the way. The pain scale. Somebody might be, don't even get me going on pain scales,
Oh,
but
I was just gonna say,
it's,
I
I
can
walked into
relate
that
to
one,
the
my
pain
head
scale.
first.
Yeah, you
But well, if somebody is unfortunately an 8 and it's a chronic pain scenario, I want to emphasize that word unfortunate. That might not change. The pain scale that I use is the DVPRS. I've said it more than 20 times, so it rolls off my tongue, but that's not going to be the case for everybody. But the DVPRS, it comes from the Departments of Defense and Veterans. Okay. So our tax dollars pay for it. We might as well use it, right? It's
Yeah.
got the usual numbers, colors, faces, descriptions, you name it. It's like every pain scale put together. That's great now. On the bottom part or the flip side of the document is 4 questions asking about sleep, function, stress.
Yeah.
So somebody might be an 8 forever. Unfortunately, again, the goal is it's part of it to improve that, but more so function. But you might help them with sleep. And I don't mean, oh, take a medicine, fall asleep. No, that's not what we're looking at here. But like
Yeah.
stress and function along the way. Whereas that number might not move. An older patient in pain might just, I've encountered this, not everyone, of, hey, doc, that 8's not moving, man. And I'm like, okay, let's concentrate on the other things to help you along the way. Uh,
Yeah.
Defining the pain situation and the goals, it's hand in hand for any patient. But I see that often with older patients of really trying to wrap our heads around what are our reasonable goals along the way.
And the first thing we do as in our culture is look for a pill to solve our problems.
Mm.
And that's what I now so what I want to talk about is polypharmacy and aging. Seniors take multiple medications. And so how does polypharmacy complicate pain management?
Whew. That wasn't a question mark. That was a period.
Yeah.
It just does. When you add on more and more medications, which is inherent with having multiple medical conditions, it's just a reality. We, in the background, have to look at the big picture. There's huge movements out there now for a lot of folks would be familiar with deprescribing. And it's a lot of pharmacists are involved in this movement that's out there. But in a nutshell, and I take heat from so many colleagues for saying it this way. Back in the day, us pharmacists would be accused of, they'll have you on one medicine, and then that'll lead to 2 more, and then that'll lead to
Yep.
3 more, and it's
Yep.
more, and that's all business and all that. And it's these days, it's more, you're utilizing 12 different medications. Inherently, there's going to be some concerns there. Let's see if there's opportunities to knock that down a little bit, to de-prescribe or de-dispense actually too along the way. Because I mentioned those, we talked a decent amount about the AGS Beers Criteria, but there's the other tools that are out there. And half of them concentrate primarily on anticholinergic, the burden, what slows you down and dries you up, essentially. Very big picture version of saying that, but that cognitive function comes into play there as well. And that's a huge thing for all patients, quite frankly, but certainly our older adults when you account for all those body changes that I mentioned earlier as well, too, and all of that. It comes into play in a major way, really.
I just did a podcast last night on prescribing. Yeah, so my because I really think it's important that we need to look at all of these things as seniors, and we have to be our own advocates because
Absolutely.
the government now is overseeing our health care, and they've ruined or interfered or just eliminated the doctor-patient relationship in many ways because they tell the doctor what they can do, what they can prescribe, and that type of thing. So we're in a situation right now where we have to be able to educate ourselves. And I think that's really important. If a caregiver is worried about a medication but feels uncomfortable questioning a doctor, how can they start that conversation in a productive way?
Ooh, I love that one because that's something I go over with. It would be for any clinician or healthcare professional, but really learners, it's an easier way to start. I always tell, I'll hone in on student pharmacists. I'll be like, listen, you're either going to be out there rounding, or you're going to be calling a doc from a pharmacy or prescriber of any type or whatever. Just, when the phone's involved, they say, don't pick up the phone until you have some information. And not something that like anybody could pull up on their phone. Because what do
Yeah.
you need it for? Everyone has the phone with them. Okay. Don't pick up that phone. Or if you're live right there in front of it, don't open your mouth until you thought through some background, some resources. Like we talked about the AGS Beers Criteria earlier, a good bit, right? You probably should be fluent in that thing before you start using it as one of your tools in making collaborative decisions, right? You can't
Uh-huh.
just be like, oh, AGS Beers Criteria said this, and it said 15 other things too. They're all relevant. Now, the
Yeah.
whole truth and nothing but the truth, quoting Jack here from the old movie screen, but most people can't handle the truth, right?
Yep.
It's important to just know what the references and resources are right out of the gate. Another one that comes up, the CDC opioid guidelines, or the most recent update.
Yeah.
Oh my gosh. One of my nerdiest moments in life, I think. I dissected that thing. I convinced more than most clinicians, just dedicating some time to it. They have 12 recommendations. The first one, they come in hot and they're like, hey, non-opioids are better than opioids for acute pain. Really? I mean, an acetaminophen is
Yeah.
better than an oxycodone, we'll say. Define better first, though.
Yeah.
Safety and efficacy. You got to balance it along the way. But when you look at the references, it's, oh my goodness, then thousands of them were actually based on review articles, including hundreds, if not thousands of cases on kidney stones, even. And I'm like, whoo, near and dear to heart. I've been there. But that's not what we're normally talking about for your acute pain. That's
Yeah.
one where it's like very pinpointed. Like when I had a kidney stone, I was drug seeking in the ER.
Yeah.
My buddy Ketorolac and NSAID. And it unfortunately, took 3 hours to get that thing. But it's not that I'm not a good negotiator, folks. It's just whatever.
I get that.
When
Yeah.
we're all the patient, you're half naked on a gurney. It's a little
Yeah.
different scenario. But anyways, what's the data behind that? It's not all a chess match, but enter those conversations having your tools all available along the way. And I think that's important on the patient side as well, too. Not that a patient needs to scrutinize every guideline, but have that information available, whatever you want to bring to the table. So,
I encourage all my caregivers and seniors to take, because doctors are only reimbursed for a 15-minute visit, to sit down and write your questions down, put them on a list, and don't be chattering about all your aches and pains, whatever it is. Be specific about what you want to address. And it's hard for people to do that. But if you can just make the doctor aware of what you want and your concerns, then you might get a sooner resolution to your issue.
that's a phenomenal idea. These days there's a lot of communication either with the prescriber or part of the team with the electronic healthcare records with messaging before or after
Yeah.
appointments.
Yeah.
I can't hurt if that's possible. Copy paste those questions from a Word document right in there, and hey, that might save you 3 out of 15 minutes where they already have them and be like, "Oh, let's go over that." I've experienced that. It's phenomenal. And
Yeah.
it shows engagement as well too. "Hey, you're on that active side. Let's take this together."
Yeah, you show your concern, the doctors
Yep,
will
yep.
listen to you. But as my personal experience with dealing with pain that many have, more with my son because than myself, but our clinicians discount the pain and they just instantly look at you as drug seeking, and it impacts the relationship. There's no trust there between the provider and the patient, and that's really sad.
Yeah, we've, at least in my experience as a patient and hearing from many others, I can only hope that I'm not one to do this for a patient someday, but it's like when you're looking at, unfortunately, rebook an airline ticket. I hope
Yes.
that doesn't bring up any trauma for anyone, but the person you're talking to is usually at a keyboard and it's
Yep.
just the fingers are going like crazy. It's like, how do you type so fast? Are you even typing or just doing that to make it look like you're busy? And we experience that in healthcare now as patients. And that's so, I always just want
Absolutely.
to say, can you just pick your head up for a second and acknowledge I'm in the room?
Yeah.
I'd prefer more than a second, but give me that at least.
I agree. I'm
But, con-
bold. I say
but
that.
conversely, the stuff's got to be documented. It's a
Yeah.
double-edged sword. Having been on both sides, it's tough.
Yeah.
But there are ways out there. The teamwork, the having folks that are everyone, not just a one-on-one for
Yeah.
visits. Is speaking to our clinicians out there, I've seen the magic in process with other clinicians where they have a team approach and it's majestic. It's hardly ever accomplished though. And by the way, I'm not trying to be hypocritical. I don't hit the nail on the head always either. It depends on what we have going on in a given scenario and our resources.
Exactly.
But
Exactly.
we could aim for it though.
Mark, if you could give caregivers or seniors 3 practical things that they can start doing today to help manage their pain more safely, what would they be?
Oof, that's a huge question. All right, deep down, I'm an academic as well too. So working at our university, read. Literally, that's it. Number one, read. Oh my gosh, yes, there's misinformation out there, but before misinformation is fine-tuned, targeted, mischievous headlines.
Yeah,
Um,
that's true.
it's like we've given up on reading the articles. Oh my goodness, I'm not trying to channel that guy from back in like the 80s and 90s with the book with the pictures that was like, who reads the articles?
Yes.
Literally, or no, anymore, no one does.
Yeah.
And that's a huge problem. Okay. I can't tell you how last year in 2025, when we had what I call Town Hall Gate, with all of the hoopla, with everything with acetaminophen, say it with me, folks, paracetamol. That's what the whole rest of the world calls it.
Yeah.
I can't tell. Every night I was up for over a week. I was up till 2 or 3 a.m. in my time zone reading articles just because I knew that people were going to be asking questions. I knew there'd be even podcast invites, interviews, all that stuff with the whole
Yeah.
pain guy thing. But if people don't do that or even just a little fraction of it, then you're using someone else's opinion and they're a dime a dozen. That is profound along the way. Listen would be number two. You know what? I'm going to try and keep these at one word each because the explanations are obviously longer, but read, listen. I don't always get the win on that. Okay. Because I'm human. Some would say it's because I'm a guy, whatever, but active listening along the way. We don't want to miss things from our patients or colleagues for that matter. And last would be care. Most people don't give a darn what you know or what you read until they know how much you care. When
Yes.
your eyes are down and typing on a screen and not looking at a patient, yeah, I know what the care level is, regardless of intention. So what do we got there? We got read, listen, and care. There we go.
Mark, how do my listeners, reach you or find information out about your
That part's easy,
pain
actually. You
guy?
could, yeah, you go to there's always LinkedIn. Everybody loves that. You can message on there as well. You could connect,
Uh-huh.
follow, whatever. But what I'd recommend for a direct route is my website. That's painguy.us. So www.paingui.us. I got a lot of career adventures on there. Got that TEDx talk you talked about. The main things are the headlines and the resources. The resources is my attempt at a one-stop shop for all things pain, addiction, diversion, and beyond. All the guidelines, the journals, all that stuff. But there's a little contact me thing.
Uh-huh.
It'll actually pop up, one of those annoying little pop-ups. I know
Yeah.
no one likes them, but then everybody uses them.
Yeah.
When you contact Pain Guy on that, my phone literally vibrates. So it's way cooler than email because I promise you that most folks don't have their email buzzing on their phone or else we'd go
No,
insane.
that's
But if
that.
you go to painguy.us and do the contact me thing, it'll come directly in my phone. Please give me a couple seconds or maybe even hours to reply, but it will come directly to my phone. So feel free, folks.
Thank you. To my family caregivers out there, you are the most important part of the caregiving equation. Without you, it all falls apart. So please learn to be gentle with yourself. Practice self care every day because you are worth it.